Okay, so welcome everyone on board. Assalamu alaikum. Today we will be discussing some highlighted points about pediatrics in journal and some of the topics of pediatric anesthesia. Okay, so we will start that like we did yesterday with the gynae ops, that because the scenario will be that you will have a pediatric patient. Okay, first of all, we will make it separately neonate and premature. Okay. So up till what year of age we call it as neonate? Yes, anyone?
28 days?
Yeah, 1 month. Okay. So up to 1 month it
1 month.
is neonate. So neonate and premature exclude whenever I'm using this word pediatric, it is from 1 month to, like you can say, usually the age group which they will be asking you will be around 3 years, 4 years, usually. Okay. So what are the journal challenges? Because the scenario will be that, for example, 4-year-old child with known case of whatever disease and going for any surgery. Okay. So the surgery may be hernia, surgery may be appendix, surgery may be tonsil, surgery may be any common surgeries which are there in pediatrics. Okay. And there will be a pediatric patient and there will be some disease. A disease may be any disease we can have. Usually the common things will be upper RTI, the common things will be like sickle cell disease, thalassemia, Down syndrome, things like that. So if you want to answer this question, okay, what should be your approach? Like, what are the challenges which we have in a pediatric patient? Who wants to answer?
So there will be
Uh,
physiological, biochemical, and
Not biochemical,
physiological. No,
physiological,
हाँ जी,
pharmacological,
anatomical and
anatomical,
pharmacological.
Anatomical.
anatomical changes leaded to challenging anesthesia management. Okay. So
Yes.
what will be? Can you just
सर
Sir,
एनाटॉमिकल में तो सबसे पहले में एयरवे का
no,
प्रॉब्लम होगा
Ifra,
वो
Ifra. So
सॉरी
I'm sorry. First of all,
जी
because there
सर
are some international people, so try to speak in English. Okay.
ओके ओके
And
सर
number one and number two, because I
ओके
think you were not there yesterday, so I will suggest that you have
यस
to
सर
think in your mind, because actually that's the
ओके सर
problem. They are in the fellowship exam or in membership exam, they are not going to ask you the changes, okay, isolatedly. They want
ओके
you to
ओके
to explain that what is the change, what is the effect on anesthesia management, and how will you manage. Okay. So now when you were
ओके
speaking,
सर
try to use minimum words, because for this answer in the 5 minute scenario, you usually you have only 1 minute maximum, only 1 minute. So think, how will you uh, just compose your 1 minute answer for all these things. Okay. Now,
ओके
okay,
सर
start please. And Abdurrahman or Hamad, please note it down. Anything missing after we finish, then I will ask you to speak out. Okay, Ifra, go ahead.
सर sir there will be anatomical and physiological and pharmacological differences which may be challenging for anesthetist.
Like
First of all, there is airway, difficult airway, and
how
for drugs.
you can, no, just a second. When you
Sir,
speak out airway, so why there is difficult airway? Just try to be concise. What is the change?
because there is interior larynx, that's
Very
why.
good.
Uh, and elongated. Sorry, sir, I haven't studied.
No
So,
problem. So anterior larynx, so anterior difficult laryngoscopy. Very simple. What's the difficulty?
yeah,
Okay.
okay, sir. Yes,
Small,
sir.
like there is a small trachea, so which can, so airway obstruction can occur very quickly. Okay. Even in
Yes,
small
yes,
normal baby. Then what else? Now, if you
okay,
think about airway, so because of
yes,
oxygen consumption, there is high oxygen consumption,
yes, mm,
and FRC is
yes, sir.
less. FRC is less, like
Yes,
you don't have much salary, or you are expending too much. So babies are managers. They are the kings. So not only they have
Okay.
high oxygen consumption, and they don't care. So they have very less stores of oxygen. So FRC is less and oxygen is more. So they tend to desaturate very quickly.
There's chance. Yes.
Okay, now the what will be the next step? Think just logically next step. So if they desaturate, they can tend to have a cardiac arrest. Okay, because if they
Yes.
have a
Yes.
hypoxia, the mechanisms to compensate for it are not very accurate, and because their heart is dependent on heart rate, sorry,
Heart
cardiac
rate.
output.
Yes.
Their cardiac output is fixed and it is dependent on heart
Yeah.
rate, and their
Heart rate.
their autonomic reflexes are not good. Usually, whenever we have any response, there is any change, we have a response from the body in the form of chemoreceptor reflex or baroreceptor reflex. So reflexes are not good, and the big boss is vagal. So vagal tone will interfere. Any problem, immediately they will have vagal response, there will be bradycardia, and there will be cardiac arrest. Okay, so now you can just correlate in the sense that they have changes or physiological, pharmacological, and anatomical changes making anesthesia management difficult with reference to airway. So with reference to airway, they have large tongue. Okay, now you can say large tongue,
Yes.
then big head as compared to the whole
Yes.
body. Okay, so uh,
Shorter trachea, neck.
short neck, short trachea, like they have very narrow
Yes.
trachea, so they can, even if the baby has no disease, normal baby, still you can have problem in the laryngoscopy. Okay, so the challenges will be that you will pre-oxygenate, you will anticipate difficult airway. Okay, you will have all the gadgets of difficult airway available. You will try to have a good position. You can put a small sheet under the head. Okay, and you can use the straight blades, you can pre-oxygenate, you will anticipate difficult intubation. So these are the things which can cover almost everything. Okay, and
Okay, sir.
then the next step automatically will be that because cardiac output response is not there, so patient, okay, they have fixed cardiac output dependent on heart rate, so you will not allow the heart rate to go down. Okay, so that's the main thing. The rest of the things, what are the remaining things, remaining changes? Just think: liver,
Sir,
kidney,
yes.
and body fluids. How will you interpret these changes, or what will you say?
Sir, there will be immature hepatic biotransformation and
Okay,
decrease blood binding protein.
okay.
So, and
Increase free drug.
increase free drug concentration.
So, like
And
Ifra, just again thinking logically, I'm telling you, which will make your life very easy. When you give the any drug in the blood, the first thing it has to tackle is the body volume, blood volume, okay, or volume of distribution. So usually they have high volume of distribution, they have high blood volume, okay, and
okay,
the initial doses may be more, initial dosage requirement may be more, then the role of liver or kidney will come. So you spoke liver first. So if you make it in an order, because of high body blood volume and high volume of distribution, initial doses may be more, relatively more. Okay, but because of increased free drug, less protein binding, immature liver and immature kidneys, the subsequent doses will be reduced. Got it?
okay. Yes, sir.
Now, in few words, you will compile your whole answer. And please cram this answer for any pediatric scenario. Like you can summarize, you can have a look on the what is written in the books about pediatric changes, and you make it in few words, which can finish in between 30 seconds to 1 minute, because they are, remember, they will not ask you a question like a class 5 question: can you tell me the changes in physiological and anatomical and pharmacological system in pediatrics? Never, they will never ask you this question. Okay, the thing which they will be asking you is a pediatric scenario who will be going with a disease for a surgery. Got it?
Okay, sir.
Okay, Ifra. So and now I will
Okay, sir.
give a chance to Hamad. Would you like to add on any pediatric changes? You want to speak out?
Assalamu alaikum. जी sir.
Walaikum. Yes.
Sir,
What again, as we are discussing, try to be very concise, to the point. No, in Saudi Arabia, we use this word girgir. So no girgir. Okay? To the point.
sir, high body surface area to body weight ratio,
Okay?
increase MAC.
Increase MAC. Why there is increase MAC?
Uh,
Okay, go ahead. We will try to find out this reason.
hmm. Rest of the thing I covered.
Okay, Abdur Rahman, please go ahead.
Sir, patient will be uncooperative. There will be difficult IV line insertion.
Okay.
Patient may have increased risk of hypoglycemia due to glucose.
Okay, just a second, Abdur
Rab-
Rahman. Abdur Rahman, because you have highlighted the pre-op problems. We have not even spoken out. So one thing is IV line. What are others? You can speak out like that. What else?
Sir, patient
Anxiolysis,
will uh,
consent issues. Okay. So these, at least these three things will be in any baby. Okay. Especially the baby who can resist. Like a five months baby cannot resist. Okay. But a
yes, sir.
stranger anxiety will come
Sorry,
after
sir.
1 year, I think. After 1 year baby, that will be more challenging. So IV line issues, anxiolysis, consent issues. So IV line issues, how can you tackle?
Sir,
Amla
either
cream,
we can apply amla cream and
amla cream, anxiolysis. Okay.
yes,
So
or we can
anxiolysis
do
we
inhalation
discussed before.
induction.
This fentanyls and dexmedetomidine, okay, and ketamine, or inhalational induction. Okay. So these are the way to, and even anxiolysis, actually, again, it will depend on the scenario. No need to tell all these things to all scenarios, because it will depend on the scenario they are asking you. Usually that will be enough. If you go a little bit detail, you can say that internationally there are dummy anesthesia masks and dummy anesthesia machines. The babies in pre-op clinic, they used to go there to have a familiarity. Okay. And then actually I have seen it. This is just my luck, like just blessing of God, Allah, that I have seen it. There are strawberry flavored, lemon flavored, very pleasant flavors masks, which are making the inhalational induction easy, because they will be enjoying it. They can use the bag as a balloon. So you can guide them that you can just have a balloon, you can fill it, and as quickly you will do it, your father will take you to like KFC or McDonald's or anything. Okay. So you can do like this. IV lines, as I mentioned, amla cream, or on anxiolysis, the route will be either oral or rectal or IV, sorry, IV intramuscular, or even intranasal. So these are the things which you can handle in the preoperative. So preoperative consent issues also. Okay. Consent issue means like they are father or mother or any guardian is the one to give you the consent. So they you can say that there are issues related to consent and IV line and this one. Okay. So what else? Anything else, Abdurrahman? With reference to airway, we miss few things, that they are like, because their tongue is big, so it can block. So they are nasal breather. So if nasal obstruction is there, there will be a problem. Okay. Then their airway is like a funnel. So maybe the tube will pass through the vocal cords, but it will stick to the cricoid cartilage. So this is another important point. Okay. So large head, the rest of the things we have, and they can ask you how to calculate an age by 4 plus 4, and this one size, what number you have to fix.
Nareem
Okay.
is inside OT and Sir Burhan is outside the OR, sir.
Okay. So the rest of the things we have already discussed, some of them. FRC is reduced. The lung mechanics are not good. The compliance is not good. The alveoli are not fully matured up to 1 year of age. So that is these are there will be higher airway pressures. If you give too much airway pressure, it can cause barotrauma. Okay. So you can see over here, I am just trying to just summarize, but what you should be thinking. Apnea time is less. Bradycardia or desaturation can cause problems. Okay, so these are the things. And with reference to post-op, same things will be there. But another thing will be that before 60 weeks of gestation, post-gestational is more less than 60. In some books it is written 50, some books it is written 60. So you should know how to calculate the post-gestational age. I'm not wasting my time in calculation. You can learn it it's very simple, like I think age and then age after the birth. So you should know how to calculate post gestational age. We will try to cover in prematurity. The rest of the things which I have already, some of them are we have already discussed. Cardiovascular system is dependent on their heart rate. Cardiac output is heart rate dependent. Vagal tone is very high. Sympathetic system is not developed very nicely. So you have to be very careful about the bradycardia. And arrhythmias can occur, heart rate can go up. You should be knowing the physiological ranges of the heart rate and the blood pressure. Okay, blood pressure usually is not a good parameter. Heart rate is a better parameter. Okay, and then renal system is not fully mature. You have to maintain a higher urine output. You have to maintain a higher urine output, and actually sometimes it is difficult to monitor. So the pampers are one thing, and of course if it's a long surgery you should have a Foley's. So hepatic system not fully mature, the metabolism will be slow. Yes, because they tend to have glucose a problem in the glucose metabolism, so they can tend to they can tend to become hypoglycemic. Okay. Then they can have some fetal hemoglobin, and there is physiological anemia around 3 to 6 months. And then what else? What else? Yes, vitamin K dependent factors. Platelet function are deficient in first few months, so you need to give vitamin K. Okay, temperature control. Temperature is very important. You need to maintain, as you mentioned, that high body remember one thing. Majority of times you are only wasting your energy in cramming the changes, but you don't know how to practically implicate. So that is more important. And believe me, if someone wants to learn pediatric anesthesia, this is the chapter or this is the topic you should know. If you know this chapter, believe me, rest of the things are very few. We will just discuss fluid management, we will discuss pain management, and believe me, rest of the things will become very, very easy, because you go to any topic, only few things will be extra. Rest of the things will be the same all the time. Okay. So in neonates, actually, there is decreased MAC and relatively higher requirement of MAC. I think even I could not myself recall. Can anyone tell why gradually there is increase? I forgot this. Why gradually increase in MAC? Why there is gradual increase in MAC? Anyone, please? Wajiha, you have joined. Zishan, anyone knows about it? Okay, I will try to recall, or if someone Google or someone knows, please put it in the chat box. So these are the things which you should be knowing. Okay, few words. Fasting time, it is 2, 4, and 6. So 2 hours for clear liquids, 4 hours for breastfeed, and 6 hours for normal feed, and 8 hours for Pakistani food. Okay, for actually six, because our food is heavy, so we should consider it as 8 hours, not even 6 hours. So 2 hours for liquids, clear liquids. Any juice with pulp will be considered as solid. Only breast milk is considered as a separate entity, so it will be 4 hours. Rest of even the formula feed is 6 hours. Okay. So these are the things we should be thinking. They have given some chloral hydrate. I forgot to mention. Actually, chloral hydrate is being used not commonly by the anesthetist usually, but by the non-doctors. They are using it frequently for a number of procedures. I have never used chloral hydrate, by the way, in my career. Anyways, so clonidine, nobody use it
It's
now.
usually used for the MRI procedures for
Yes,
the
MRI
children's.
and these. Yes,
50,
yes,
50 milligram per kg we are using in our setup.
yes.
Okay,
Okay.
but it is long acting.
Yes, yes. So, okay. So some words about the fluid, Abdurrahman. What will be the concerns with reference to fluids? In previously there was a concept to use hypotonic fluid. So that was a killer solution, which was 0.818% normal saline with the 10% dextrose water. That was called as PEEDS solution. So actually, this is a killing solution because already they are not a very good conserver of on sodium, so that they tend to become hyponatremic, and it's a very bad solution. So the recommendation is always to use balanced salt. Okay, so ringer lactate is a good choice. They can use normal saline as well, and especially because for any fluid management there is one is deficit, one is maintenance, one is third spacing, okay, ongoing losses, and insensible losses. So for any calculation of fluids, so you can say that for maintenance, it is better to use because we have to take care of caloric intake as well. Sorry, hypoglycemia as well. So usually 5% dextrose, half normal saline, or full normal saline can be used for maintenance. And for these things, it's better to use the isotonic the fluids. Okay. So this is the basic principle. And rest. If any baby who is tend to have hypoglycemia, so for that you can separately use 10%, or you can like make a mixture. So no need to give 10% dextrose water to all pediatric patients. It's not recommended. Okay. So you can have this maintenance and deficit. And for any patient who have any metabolic problem or any tendency to get too much hypoglycemic, then you can use isolatedly. You can check blood sugar 30 minutes to 1 hour and like that. So this is few words about fluids. With reference to analgesia, very simple, paracetamol. Okay. So paracetamol even may be used in suppositories. Okay. Even there are diclofenac sodium. If there is no contraindication, uh, diclofenac sodium can be used also. It's also being used in suppository. Then the rest of the things like opioids, like fentanyls. The problem will be that these babies, especially if any baby in which there is chances of post-operative apnea, you will try to avoid long-acting opioids like morphine. Even in day case surgery, there is like some people will use it, some people will try to avoid it. There is no absolute content.
Caudal epidural analgesia is a very good option. And
Yeah, just a
in
second.
case
Just a
of
second. I'm Zulkarnain, just let me go in order. So opioids, okay, and then opioids, of course, as I mentioned, that some of the opioids can be given like intranasal or so in an order you can go, and then regional anesthesia as Zulkarnain is mentioning. So caudal. So with the caudal, remember one thing, that caudal is one of the blocks which has relatively higher absorption. This is number one. Number two, if you are using in relatively bigger babies, dose calculation and dosage is relatively easier. But if you are using in very small babies, sometimes it becomes very tricky. Usually we are using 0.25%. Okay, and there is an Armitage regime. Can anyone remember Armitage regime?
Sir, 0.5 ml per kg for up
It
to lumbar.
according 0.5 to 1.25 ml per kg according to the level you are requiring. This is number one. Number two, the concept will be that you have to calculate the safe dose. So which is 2 milligram per kg for bupivacaine. Okay. So for example, if you are calculating for 10 kg, so the maximum dose will be 20 milligram. Okay. So if you are using 0.25%, so the maximum dose you can take will be how much? How many mils? In 1 mil, it is 0.25, sorry, 2.5 milligram. So you maximum you can take is 20. So it is 8 ml. Okay. Am I right in calculation or wrong? Okay. So it is maximum 8
Yes,
ml.
sir.
Now next step will be that, for example, according to this formula, if you want more than 10 ml, more than 8 ml, for example, you will dilute. Like for example, you will take the remaining the normal saline. So this is the concept that volume will be for spread, and safe dose will be calculated through 2 milligram per kg, and then you will convert it to 0.25%. So it will be 2.5 milligram per kg, sorry, per ml, 2.5 milligram per ml. So this is how you will calculate. So you will not go for the mls first. Even if they are asking you about caudal epidural, tell that we will calculate the safe dose for the baby first. So that will be 2 milligram per kg. And then whatever maximum, you will take that ml and you will dilute to make it according to the volume. Okay. So this is the basic concept about it. So epidural can be used for any procedures like circumcision, any urological procedures, hernia, even abdominal procedures. They can give according to the, as I mentioned, zero point 0.5 to 1.25 ml per kg. So coming back, paracetamol, diclofenac sodium, ketamine is a very good choice for analgesia. Okay, if you want to give it in a smaller dose. And Presidex, again, it can delay the recovery, or opioids, short-acting opioids and long-acting opioids intraoperatively, like you can use remifentanil, fentanyl, or but try to avoid the long-acting ones. And then regional blocks. So again, with the same problem will occur if you want to give tab block, say, so again, the same problem will occur about the volume. So it's very difficult to calculate the volume. So that's why you have to, and of course, because this is a subspecialty, so I don't think so they will be asking you too much details about it. Okay. So the basic concept is that you should understand how to have the safety. How to have the safety. The safety, if any block you want to tell, you will tell that I will calculate the safe dose first. And then you will calculate the volume. You cannot calculate the volume first and then save dose. So this is a trick. So this is the basic concept about very simple, because I'm not telling you very difficult things, very simple things you will never forget, and you should never miss it. And I think just a second, analgesia. So okay. So actually, so this is again, up till now, we have just tried to cover the basic concepts about the challenges in pediatric anesthesia. Common questions which they will be asking you, we will just try to go one by one, and you will find what are the difficult, sorry, what are the common thing which they ask. So we start with Down syndrome. So what is Down syndrome, Hamad?
But it is the most common congenital abnormality.
Why you need to tell this is most common congenital anomaly? This is the problems which you will hit yourself. I have asked you how common it is. Till the time they don't ask, why are you telling like this? You understand my
Okay.
point? This is just to
Yes, sir.
invite a problem without any reason. Okay, please go ahead.
Uh, uh, in this syndrome, there is cardiac defects, endocardial cushion defects, ventricular septal defects, atlantoaxial instability,
Okay. Hypothyroidism, epilepsy, difficult intubation. Speak out, speak out.
Yes, sir. Sir, mentally disabled होंगे सर और
Mental retardation.
mentally disabled होंगे सर और जी और repeated chest infection की वजह से आप उनको
Can you
restrictive lung
speak in
disease हो
English?
सकती है
Abdur Rahman,
they
please
may
speak
have
in English.
yes sir
Respiratory tract
yes sir sir
infections.
due to repeated chest infection they may have chronic lung disease and
Okay. What else?
association with
Is it associated with this VAC, Vater
some
and Vector?
facial features.
No, sir. Down syndrome is not associated with
No,
Weber.
sir.
Okay.
Down syndrome is
Sir,
basically
no.
the commonest chromosomal abnormality. Okay. And it is also referred to as trisomy 21 due to the presence of an extra copy of chromosome number 21. It has incidence of 1.5 per thousand live births. This is the definition of Down syndrome. If the examiner is asking Down syndrome definition, you will give a definition, not the characteristics and general appearance. He's not asking the general appearance. He's asking the definition of Down syndrome. So you are be very specific about the question.
Okay.
Okay.
Okay. So these are rest of
Subglottic
the thing.
stenosis.
So OSA, there is high incidence of OSA, subglottic and tracheal stenosis. There is short trachea. So you will be using a smaller size tube as compared to the possible prediction for that age group. Okay. Then neurological problem, hypotonia, okay, epilepsy, and atlantoaxial instability, and this is important, gastroesophageal reflux, and there may be atresias. Okay. So when they will ask, because usually the scenario, it can be that they will ask you that there is a 4-year-old child with the known case of Down syndrome for adenotonsillectomy. Okay, I'm giving you one example. So, you will be telling the concerns about 4 years baby, all the challenges extra. Then you will tell about Down syndrome, and then they will go towards the adenotonsillectomy. So whenever they are asking about adenotonsillectomy, always you have to, in preoperative assessment, of course, you have to find out a window period from RTI, respiratory tract infection, because you cannot have total relapse, unfortunately, because they have recurrent problems. So they have to find out a window, and if there is, you have to do it risk versus benefit. So you will have a multidisciplinary team, and then you will decide whether you have to proceed or not. Usually, if it is a significant RTI with significant sputum production, fever, respiratory sign symptoms, then you will consider for postponement for 4 to 6 weeks, which is like. But again, in this scenario, you can tell that because they have frequent repeated infections, so you have to do risk versus benefit. You have to try to find out a window, and it will be a multidisciplinary team decision to do it. OSA, they can have OSA, so you have to think about it. But remember one thing, that sometime the reason of OSA is adenotonsillitis, like adenoids and tonsil. So you cannot fully recover unless you remove the tonsils again. So it will be risk
There is
versus benefit.
difference between childhood obstructive sleep apnea and adult obstructive sleep apnea. In childhood, palatoeuloplasty, like adenotonsillectomy, is curative. If we go for surgery, they are free of OSA symptoms. But in childhood, cannot. This is
Yes,
difference between COSA and adult OSA.
yes. Yes. Okay. So I hope you understand. So that will be the possible simple answer related to this scenario. And of course, we will have few words about post tonsillectomy uh, bleed. Just a second. So because this patient is at risk of uh, bleeding. Okay, so if they will ask you about this scenario, maybe their option, like if they are asking you about post tonsillectomy bleed, okay, so what will be the challenges? Abdurrahman or anyone wants to answer this question? Zishan, please, you have not participated.
Yes,
Please answer.
sir, apart from the anatomical, physiological, and pharmacological we have discussed above, and the Down syndrome, a specific problem related to tonsillectomy will be shared airway between the anesthetist and the surgeon,
Okay,
increased chances of bleeding, increased chances of rebleeding.
okay.
The technique used by the surgeon, what technique is he using? In, mm,
Just a second. Just a second. Shared airway, the tube can dislodge. So you can tell about this.
yes,
Bleeding and rebleeding.
yes.
Technique. Technique. What is the role of technique?
Sir, I think when the surgeon is using hot technique, there is an increased chances of rebleeding, sir.
Rebleeding and more pain.
More pain.
Okay, so and this is one thing. The other thing is that like you have to, because this is not your domain to tell you which technique you should use. Usually they are not doing it on one technique. They are crushing it, they are putting stitches, they are using cautery. So they are actually, in reality, they are using not isolated cold technique or hot technique. Usually they are using a combination, but you should just have an
Combination.
idea and you don't need to overdo in to start with. Make go very simple, and if they want to go in details,
Okay.
they can ask you in detail. So the now, for example, they will take you to a place that the patient rebleed. So how will you evaluate in this scenario?
Sir, when the patient is rebleeding, I will assess the patient on
Sir,
the
a rebleeding
airway.
patient.
1 minute, just let him speak, please. In bit, no, don't interrupt in between. Okay, let him speak.
Sir, I will assess the patient and start with airway, breathing, and circulation. I will give 100% oxygen to the status pass to wide and assess the breathing of the patient and pass a wide bore IV cannulas and start fluid resuscitation of the patient and assess
How
the
will you
hypovolemia of the patient
how will you
on
assess
clinic.
hypovolemia?
Then we can assess hypovolemia on clinical signs, which could include vital signs such as heart rate, blood pressure,
Just a second.
SpO2,
Just
and
a
then
second.
clinical signs.
Just a second. Is blood pressure a good indicator in pediatrics?
No, sir.
Is
Not
even heart
a
Heart
rate?
good
rate.
indicator. Heart rate.
Please let him speak. Don't interfere in between. I want to give all of you chances. If you note, if you find anything missing, please, I will give you a chance after that. Raise the hand. Anyone wants to speak out, please raise the hand. Yes, Ishan, please continue. So there are clinical
Yes,
sign
sir.
symptoms which reference mucous
Clinical
membranes.
mucous membrane,
If it is a smaller
capillary
baby,
refill.
fontanelle. Of course, not. It will not be
On,
valid in 4 years. But I'm just telling you how to assess fluid volume status in a pediatric patient. Okay. So
sir, we
fontanelle,
can assess skin turgor, sir.
skin
Eyes,
turgor,
patient
sunken
sunken
eyes.
eyes if the patient is. Uh,
Yes.
then we can have patient could be irritable or he could be drowsy, lethargy, depending upon the assessment of his dehydration, sir.
Yes.
And
So what about urine output?
the urine output is also a good indicator.
You have to tell. It's a good indicator. If the
Yes, sir.
baby is not wetting the pamper, it's a bad sign. Okay.
Yes, sir.
And in this scenario, because you cannot assess the volume loss exactly. Okay. So you have to be how will you assess? Because they swallowing the blood. So you cannot assess the exactly. So you have to rely on these things. You told about vital signs. So mention that blood pressure is not a very good sign. Even heart rate changes because of anxiety, because of hypovolemia and relatively higher baseline heart rates. So sometimes it's very difficult to interpret only on the heart rate. I'm not saying this is not the
Okay, sir.
criteria. So and then you will label it as 1 to 5% or 5 to 10% or more than 10% dehydration. So this is a basic thing. You will fit it in any scenario of pediatrics volume depletion, whether it is infantile hypertrophic pyloric stenosis, whether it is STOF, whether it is congenital diaphragmatic hernia or anything like that, in which sorry, this one inna lillahi wa inna ilaihi rajiun, this intestinal obstruction, vomiting, gastroenteritis, typhoid, anything in which. So these are the basic things you should be knowing. What are the clinical parameters? What are the sign symptoms? How will you assess the severity of dehydration? This is valid in any scenario. So it's the same thing. According to the age, you will say if the baby is 4 years, no, don't tell about fontanelle. It's not valid. Okay. You tell the things which
Yes,
are
sir.
relevant. I hope you understand. So if anything miss, you can see, but this will be the answer, default answer for any pediatric fluid status assessment. Okay. Of course, in any other case, I'm not sure. I have not used it, so I cannot. I'm not sure what about the use of cardiac output monitors. I'm not sure about it. I don't think so. You need to go in that much detail because usually, even this one is enough for you. If you tell this, maybe you will not. They will not fail you. Okay. So and another important thing is the next step with reference to it will be trigger. Transfusion triggers, and
Yes, sir.
then you should be knowing that here it's very meticulous because maybe in adults the blood loss, even a lot of blood loss is not a problem. But if you have a 5 kg baby who has a blood volume of around 400 to 450 ml, okay, 80 ml per kg if you take it roughly, I'm just giving you an idea. So 400 ml, if it is a total blood volume, even if we lost 100 ml, it's a big loss. It's one-fourth of blood. Okay, so it is 25% loss. So that's why you have to be very meticulous. And then usually you will replace the blood according to the hemoglobin 10 to 20 ml per kg. Okay, and then you they can ask you exactly how much hemoglobin will raise. I don't remember exactly, but usually 10 to 20 ml per kg they give the blood. Am I right? So this is how the
Yes, sir.
sequence will be starting. Assessment of volume status. How will you calculate the how much volume is lost? Of course, the same surgical site, gauzes, drains, but again, because in babies the margin is very less, and you have to be very meticulous. So, if any change in hemoglobin or hematocrit, you have to anticipate very quickly. So, this is the basic. So, up till now, if we just revise, we discuss about the challenges, induction, maintenance, recovery, fluid, analgesia, volume replacement, blood replacements, and blood and products like that. So, these are common things. We discuss about this. Tonsil, few points are missing about the tonsil. That this patient will be full stomach. So you will consider if it is like you are expecting, maybe you can put NG. But if you tell about NG, again tell the same thing, that placing the NG preoperatively can actually predispose the patient for aspiration because of loss of lower esophageal sphincter tone. If you don't put it, if it is like if you are expecting a lot of volume bleeding, then it can cause problem. So there is no fixed answer. There is no, you don't need to tell you have to do it or don't have to do it. If you will do it, it has advantage that you will empty the stomach. If you don't do it, there will be chances of aspiration. If you do it, again there are some things. So you have to manage according to the situation. You can say if you think the stomach, you can even palpate, and then again if you can say that if you have facility, you can have the residual stomach volume, and then it can tell you that do you need to put NG or not. Okay, and history can tell you that if there is solid intake, there will be not much advantage you will count, because you will not be able to aspirate the solids. If you have liquids, or you in this scenario, because maybe there is blood, so maybe you can aspirate it. So you should be knowing what you are doing. If you know what you are doing, things will become very easy. Okay, so now we will go forward because this is slightly easier and easier to explain. What is infantile
And
hypertrophic bile duct
Dr.
stimulation?
Dishan, this
Yes,
slow blood pressure is the hypotension is a very late sign, and
late sign.
conscious level also we will assess. And
Yes,
the
conscious.
problems really, if frankly speaking, the problem with post-tonsillectomy hemorrhage, there are five problems for those who are preparing for Viva. Fertile child, okay, and anxious parents are anxious. There is hypovolemia, full stomach, residual effects of anesthetic gas drugs, and difficult intubation. And
Very good.
regarding the indicators of hypovolemia, always remember heart rate, pulse volume, capillary refill, skin color, blood pressure is a late sign. Conscious level also. And blood loss is always, underestimated in case of post-tonsillectomy bleeding. Also, there is one question they ask, Yani, what is your technique? So always remember, if whether there is chances of difficult intubation or not, always go with rapid sequence induction with cricoid pressure. Always mention this one. So you will get good marks. An ENT surgeon should be ready for tracheostomy in case of difficult intubation.
Yes, very good. Okay, so infantile hypertrophic pyloric stenosis. Ifra, now please speak out. Yes, Ifra, what is infantile hypertrophic pyloric stenosis? Please.
There will be a hypertrophy of pyloric canal, and there will be olive-like mass will be palpated in the abdomen, and there will be bilious vomiting. Child present with bilious vomiting.
Non-bilious vomiting. If you
Not
say bilious
no
vomiting, non-bilious vomiting.
Sorry,
Okay.
non-bilious vomiting. And first of all, we have to manage this patient. After stabilizing the patient, we will prepare for surgery. And that's it.
This patient is with hydration.
Infantile pyloric stenosis is the most common surgical condition presenting in the 6 months of life. Males is having 4 times higher ratio than the females, and the incidence is 3 to 1,000. If you don't know the incident, do not quote the false or wrong incident. If you are sure, then you will say. So it is most common surgical condition presenting in the first 6 months of life. This is definition of infantile pyloric stenosis, associated with non-bilious vomiting and with no hyponatremic, hypokalemic, hypochloremic metabolic alkalosis. Okay.
Okay, so the problems here are because the patient is
Oh,
not, there is vomiting, dehydration, electrolyte imbalance. So what are those electrolyte imbalance? Now, if you understand logically, you will never forget. What is in the stomach? So there is a hydrochloric acid, so hydrogen will be lost, chloride will be lost, potassium will be lost, sodium will be lost. Okay, so hyponatremic, hypokalemic, hypochloremic, when you are, so this is hyponatremic, hypokalemic, hypochloremic, metabolic alkalosis. Okay. Now the last thing which is making the last thing is paradoxical aciduria. How it occurs? Paradoxical aciduria, Ifra?
sir, I don't remember.
Okay, the normal
Sir,
body
first,
response. Just Abdur Rahman, if you want to speak out, because what's the problem? I want to cover as many topics as possible. So that's why I'm in a little hurry. We cannot cover each and everything. That's why I'm not very interested in too much details. I'm giving you a basic concept. And if you know the basic concept, you will never fail. I can bet on it. Okay. So immediately tell, please, Abdur Rahman, paradoxical aciduria. How will you explain?
the first, sir, at first the body tries to compensate the loss of acid uh, releasing by producing alkaline urine, and then when acid loss is become greater, then
No,
the
no.
body starts
Aldosterone
I
actually
think
retains sodium and release potassium. Okay. So, to conserve sodium, they have to lose potassium. But now when the potassium becomes too low, it is incompatible to life. Now, instead of kicking potassium, they will start kicking hydrogen. So that is called as paradoxical aciduria. Okay. So initially, aldosterone will try to compensate, but when the compensatory mechanisms are exhausted, so then will return. Then again, remember one thing: all these incidents or all these common things and uncommon things. I know that they are asking you a definition. You have to tell, but again, this is not failure point. They will not fail you if you are telling these things correctly. I can bet on it. They will never fail you on these points. Yes, number making a very good number, that is something else, but try my whole concept of these classes and this is to give you a basic understanding, because sometimes you fail on very simple things, not very small, tiny, teeny things. Okay. So if you don't remember that how this occur, how this, you will, if you try to cram hypochloremic, hyponatremic, you will forget. In the exam anxiety, you can forget your name even. So how will you cram this? But if you understand, oh, okay, there is acid, and why Zulkarnain was stressing that it is non-bilious, because if the door between the stomach and this is closed, how bile will come? Just think logically, Ifra. You were saying bilious, how bile will come? If you are telling bile, it means you don't know the pathology, because this is the difference between the normal vomiting. In normal vomiting, because bile is also coming, so it is neutralizing. Here there is already alkalosis and there is no loss of bicarb. Okay, so it is causing more and more metabolic alkalosis. Normally, when bile is also coming in our normal vomiting mechanism, because bile is also sometime coming. So actually, the metabolic disorder does not occur in this way, which occur in infantile pyloric this alkalosis. Sorry, in this pathology. Okay, and then they can ask you a cramming question, that when will you say that the patient is ready for surgery? So of course there is a specific answer for it, but generalized answer will be the dehydration is corrected, electrolytes are corrected, urine output starts pouring, then you will go for surgery. It's a medical emergency, not a surgical emergency. Then you will be doing, because there is stomach is full, so you can measure the stomach volume and you can do a 4-quadrant suctioning. These are the main points which you can tell. Again, these were the things which I was discussing. Okay, about the fluid loss, how to calculate. This is, you can see the chart. Then this is also a bookish question. Targets for resuscitation: chloride, sodium, bicarb, chloride, urinary chloride, urine output. But usually, I don't waste my energy or on making you cram these words. Okay, because in my opinion, if someone forget, he does not know, but he can make him understand that it is the dehydration which is corrected, urine output started correcting. Okay, sorry, urine output started coming. Okay, and the general uh, level of consciousness improves. Okay, and electrolytes becomes normal. This is the target which you want. Yes, if you will speak out like this, of course they will be impressed. But again, because I am never able to cram these words, so I never ask anyone to cram, because I have passed, or so many people pass even without cramming these words. So of course there is two different school of thoughts about it. In some things, basic concepts never change, so my focus is always to tell you the basic concept. Okay, so this is the scenario. They will ask you, when will you proceed? You will say, when these things are get better, then we will proceed. And these are the things. Then the cauliflower, you know, because Ifra, I want to understand why you were telling about cauliflower and cabbage, and why you are interested in telling the surgical things to start with. Why you did not tell that there is dehydration? Why you are trying to reproduce only the bookish words? The examiners are very smart. Okay, if you
Okay,
tell
sir.
these things and you don't know the way, after that you have started stammering, your answer will be incomplete. If you tell cauliflower but you are not able to make a good food, they will never pass you. These things will look good if you are having a grip on the rest of the things. That is the thing which I want you to understand. Please
Okay, sir.
don't reproduce the bloody words of books just for the sake of reproducing them. If you don't understand, believe me, if you don't know, examiner will smell that this gentle lady or gentleman knows about the subject or not. So these are the things which will pass you, are the basic concept: dehydration, electrolyte imbalance, what is going on, why there is no loss of bicarb, because it's blocked. Okay, so now we will go to the next pathology, that is this exophthalmos and gastroschisis. So this is actually problems with the abdominal wall. Okay, so when abdominal wall is open, what will happen? There is chances of things to be injured. Number one, because abdomen is open. Sorry, abdominal wall is open, and the contents they are losing a lot of water. So there is dehydration. Okay, So now you can go in details. What is difference between exophthalmos, sorry, exophthalmos, this omphalocele and gastrochisis? Who will tell? Hamad, or any other exam candidate, please.
Sir, in omphalocele and gastroschisis is not associated with congenital diseases, but omphalocele is associated with congenital diseases. And the location in gastrochisis, the location is usually on the lateral side of the umbilicus, and in gastrochisis, it can be
Omphalocele,
anywhere, sir.
omphalocele.
Omphalocele, sir. And in gastrochisis, there is no covering of, there is no peritoneal covering of the gut that is coming out. But in omphalocele, but in gastrochisis, there is no covering, and there is increased chances of dehydration and infection. And uh, and gastrochisis is more dangerous than omphalocele because there is a more chance of rupture.
Yes. So actually, these are the things which you should know. And the rest of the things, believe me, the same. The same pediatric or neonate consent. Neonate because we did not do in detail, but the basic things will be the same. So these few points, and of course, again, they can ask you about incidences. I am not saying that they cannot ask about incidents, but they will not fail you. This is just, a teasing point. They are just checking how good are you. Are you able to, you are becoming a consultant, you are becoming an anesthetist. You will be eaten by the surgeons. You will be eaten by the paramedical staff. So, are you able to tolerate these teeny tiny distractors? Okay, so they just want you to understand or know about it. So these are the things. Actually, these are maximum things which you see, herniated thing, a bowel decompression using NG, and then all the patients, such patients, any babies, you should be knowing that there will be chances of this dehydration, electrolyte imbalance, and then this problem with the temperature regulation. Rest of the things are the same. You read it about it and you will find the same thing. Okay, we missed this thing. We will cover here. How to monitor, and how to maintain the temperature in the pediatrics or neonates. Yes, please. What will you tell about it? Wajiha, you are silent today. Are you are you fasting?
No, sir, my internet is unstable. When I speak, it this.
No, please try to speak. Try to speak, and I will request you to have a good internet connection. Put some water on your mobile so that it start working.
Yes, sir.
Okay, speak out. Temperature control, temperature management. How will you do?
Sir, first is of OT temperature increase. For children, it's 28, I think 26 or 28 degrees C. And then measures to warm blankets and warm sheets. And then we wrap with,
Uh,
even in
Air
our
hugger,
setups, we wrap
air
plastic
hugger,
sheets.
air hugger.
And then where
Air
he
hugger is a
can.
warm air device. Okay. Then you will maintain the ambient temperature. Start with the ambient temperature. Start saying we will be using warm fluids. Okay. We will be maintaining that theta temperature. We will be covering the babies. We will just try to have an exposure as much it is needed. Okay. And you will use the humidifier. You can use
Humidifier.
humidification of the inspired gases. Okay. What else? Anything else? Then the fluid warmer as well. So warm fluid
Fluid.
or fluid warmers. Okay. And theta temperature and monitoring core temperature. The most reliable one is pulmonary artery catheter. But here, of course, you will not put pulmonary artery catheter to monitor the temperature. So you can use this middle one third of esophagus, that temperature, or nasopharyngeal temperature, or rectal temperature. Rectal temperature is more reliable, relatively 1 degree centigrade higher, but the reading, whatever reading is coming, is more reliable because it's a closed space, and it will, of course, but it's a careful thing to place rectal temperature because it can cause bleeding. So these are the things. Of course, there is this tympanic membrane also calculation, but usually it is how you have to monitor. So skin temperature not very good option, because if you have put a bear hugger and you are monitoring the temperature, it will be coming higher. Okay, so this is the common to any scenario, that these are the things to control. So indifferently, we have discussed about airway management, we have discussed about fluid management, we have discussed about the temperature management, you have discussed about the analgesia. So these are the common things which you will can put it in any scenario they are asking you. Okay, always anticipated difficult intubation, and of course, like any scenario, if it is there is like risk of aspiration, so you will be doing this one in the Rajun rapid sequence reduction. Okay, so the next topic will be uh, congenital diaphragmatic hernia and TOF. Okay, so what is congenital diaphragmatic hernia?
So it's a congenital disease in which bowel contents protrude into the thoracic cavity.
Because of defect,
Uh,
because of defect in the
The,
diaphragm. Simple, very simple. Okay.
the,
So in the development, if it is congenital, because the abdominal contents will be in the thoracic cavity. So thoracic cavity will be, they will be pressing the lungs, and lung will not be matured. And when they do the any radiological study, they will found the bowel contents in the in the chest. A number of time it is diagnosed antenatally. Okay, and the main problem in this patient will be lung maturation. Okay, and again, the answer is that you will try to make sure that the lungs are matured. Lungs are get matured rather than doing the surgery. Because if the lungs are not matured, the baby will not survive. And these are the patient which will be premature. So now we can have some words about the prematurity. So we will just have a look on prematurity first. Just a second. Premature article. Where is it? Okay, what are the concerns in prematurity? Yes, please. Few words about prematurity.
Sir, prematurity is defined as the life birth before 37th week of gestational age, sir.
Okay.
And and all the physiological, pharmacological, anatomical changes including airway and respiratory system, is that the in premature babies, the patient alveoli are not developed. They are not developed. The surfactant is also fully not produced, and their lungs are non-compliant. So there is increased chances of V by Q mismatch and easy desaturation, and their closing capacity is also within the range of their tidal volume.
One thing,
Uh,
Zishan, in this part only, just add one thing, that because if you are giving much oxygen, there will be more chances of respiratory distress syndrome. Okay, so you
yes,
try to give minimum oxygen.
keep the saturation between 92 to 90.
Okay,
And then increase chances of because of giving high oxygen, they can have bronchopulmonary dysplasia too. Their
dysplasia.
pulmonary can also, yes, sir.
Yes,
And also ocular damage. Retina can also be damaged from use of
again because of
high oxygen.
new. This is the word, beautiful word you can say is new vascularization. Okay.
New
It can cause
vascularizations.
new vascularization and cause retinopathy. So it is a retinopathy of prematurity. So one are respiratory things with reference to alveoli, with reference to post-operative apnea, with reference to bronchopulmonary dysplasia. These are the thing. Okay. And then
Yes,
high oxygen consumption and high metabolic rate and rapid desaturation. And these are the things. Cardiovascular, actually almost the same, but here they can ask you about fetal circulation. Okay. So you all of you should be able to explain fetal circulation. Fetal circulation, you should know how it is connected and what are the changes which occur at the birth. What are the changes at the birth? Because here in the prematurity, these things are there. Either there may be some congenital heart disease, okay, or there is patent ductus arteriosus. So when there is patent ductus arteriosus, what will happen?
Sir, pulmonary hypertension can happen in prolonged PDS, or if the PDS
If it
works
is
not.
Right to
so,
left shunt.
usually there will be right to left shunt or left to right shunt.
You
If the shunt reversal happen, then we can say, but
Usually
usually
it
there
will
is
be usually there will be left to right shunt. Okay,
left to
initially
right shunt. Yes, sir.
left to right shunt, and then the reversal is called as Eisenmenger phenomena. The Eisenmenger phenomena will
Yes.
occur later on. Okay, and then okay, what else? Renal extra, the same things. They are not able to handle. They are not able to handle to concentrate the urine, and they cannot handle the water. So they are tending to lose water despite
Sodium.
despite high level of ADH. Okay, so that's why they have hyponatremia, and hyponatremia always cause neurological changes. Okay, so then brown. Okay, when we are discussing about temperature, we forgot to mention about brown fat.
Mhm.
So what's the
Yes.
concept of this brown fat?
Sir, in normal individual, shivering is not present, so the heat production is from the brown fat, which is present in between the scapula, in around clavicle, uh, and sir,
I
it's
think
present around in certain location.
pelvic
Pelvic,
pelvic
yes,
brim
sir.
also. I'm not sure. So you should be knowing about it, that where the brown fat is there, and they though usually we produce fat produce heat by shivering. So they have non-shivering heat production. Okay, and hematological system, fetal hemoglobin. So fetal hemoglobin, there is leftward shift of oxygen hemoglobin dissociation curve. Okay.
And also they have vitamin K factor deficiency in premature.
Yes, so vitamin K can cause spontaneous hemorrhage. Okay, they can have spontaneous hemorrhage as well because of bleeding tendency. Okay, so these are common things, and they can ask you about the stages. Like there is, I think, stage one, stage two, was not stage, class one, class two, class three, according to weeks of gestation. Okay, they can ask you about prematurity in this regard as well. Actually, majority things are the same. You have to calculate you have to think about the post-gestational age, post-operative apnea, impaired gas exchange, this lungs maturity issue, premature retinopathy of prematurity. So these are the things which should be doing it. Okay. Mm, ECG via needle electrode, non-invasive capnography. So Mapelson F for mechanical ventilation, sorry, for ventilation. Dead space must be minimized. Hyperventilation, hyperoxia. Airway pressures. Airway pressures are very important. So general concerns I have told you: inguinal hernia, PDL aggravation, laparotomy, MRI. They will be taking. These are the places where you need to take them. Okay. So now coming back to congenital diaphragmatic hernia. So congenital diaphragmatic hernia is, as we mentioned, that there is a defect. Okay. So um, abdominal contents are there. They are not able to, if they want to just tease you, they will ask you about these things. What is this foramen of Bojlak and foramen of Morgagni, which I will never, I never cram it. So if you can do it, I will be very happy, because some of the examiners, of course, they can ask you such things. But again, I can guarantee you that these are not failure points. So please don't waste your energy. If you are very good, do it, because this is a big contrast between me and some of the other people. Because remember one thing, the thing which you cannot recall, if you don't have the ability to cram these words, what you should do? Should you leave FCPS? No, I can guarantee you still you can pass. You can manage now the rest of the things. You should have a very good concept. Okay, so like this will be the failure point. If you don't understand, there is pulmonary hypoplasia, there is vascular remodeling and pulmonary hypertension. Okay, and then there is left ventricular hypoplasia. This is the concept behind what is going on. If you don't understand this thing, you don't understand what will be the role of ECMO, what will be the role of this steroids. They give lung protective ventilation. Okay, and then we
Protective
keep
ventilation. Okay, and then we keep
the patient in an ICU till the time they get the desired results, and then the surgery will be done. Okay, so what are the associated anomalies with the congenital diaphragmatic hernia? Yes, please.
the patient can have a VSD, or a patient can have pulmonary hypertension after hypoplastic lung. These two are most
Actually,
prominent.
the difference will be here, Zishan, that because these patients, they have congenital problem. Okay, so usually they will have pulmonary hypertension to start with a number of times, because the lungs are not mature at all. So at the time of birth, the normal changes which occur in normal baby, unfortunately here, lungs will not be able to expand properly. There will be persistent PDA. So there are so many things. So they are not able to achieve to come out of the fetal circulation. So when the fetal persistent fetal circulation will be there, there will be more chances of development of pulmonary hypertension. So this is one thing you should be knowing. And then the rest of the thing will be that when you are trying to intubate, you will avoid excessive airway pressures, because it will cause uh, pneumothorax. Even when they ask about this case in the exam, the thing which they are asking you, that suddenly there is intraoperative one side patient desaturated, and there is high airway pressures. So differential diagnosis is pneumothorax. Okay. So when they will be asking you this question, how will you evaluate preoperatively? So preoperatively, now you can just think about it. You will be doing the things which will be required will be of chest X-ray, radiological studies, echo. Okay. In addition to the other common investigation which we can do in any other patient, and
Sir,
then
can
they
we
will try.
do ABGs, sir? ABGs
Yes,
in this
yes,
patient?
yes, yes, of course. And ABGs will be this point I wanted to just show you, that right radial artery will be preductal. Do you know the concept of this preductal?
Yes, sir. Brachiocephalic artery bifurcates
PDA, before ductus
yes,
arteriosus. So when
before
the
ductal
tree
artery.
is so that's why when the tree is coming out, the aorta is coming out, the like before the ductus arteriosus come, the right brachiocephalic trunk comes out. So that will be the pure blood. The not I'm using not the pure blood, the more accurate blood which will have, because after that there will be mixing of blood. If there is shunt reversal, there is mixing of blood. So if you want to monitor, the most reliable will be right radial artery. Okay, so that's what they will be doing, echo, and then you can say if needed. Next step with reference to cardiac or pulmonary things. Later on, these babies they also have studies of pulmonary hypertension with right heart cath and everything. So because the accurate measurement will be through it. Um, and then again, such charts you should be knowing how will you do immediate intubation, pre and post ductal saturation for post ductal in case of pulmonary hypertension and reversal of shunts. And this is a measure. NGT insertion with frequent or continuous suction. IV access, umbilical line may also be used. Transfer to ICU, invasive blood pressure monitoring, ECMO. You can add ECMO to these things. Okay. So permissive hypercapnia, airway pressures, relatively low requirement of high. There is requirement of high FiO2, but you try to avoid high FiO2 because it will create more and more problems. Okay, so that's what they maximum they can ask you about this topics. So pulmonary vasodilators, they are using sildenafil, nitric oxide. Okay, right heart contraction, milrinone. Milrinone actually is, what is milrinone?
Sir, melanin is a phosphodiesterase which
Phosphodiesterase.
increase the contractility of the right heart, and it
Right
also
heart, and it's a
vasodilators.
vasodilator. So if it anything which is causing vasodilator can cause actually hypotension. Okay, so it increase the right heart contractility by decreasing the pulmonary vascular resistance. Okay, so that's why sometimes maybe you need to have norepi on background of milrinone. Okay, so mm, these are the things. Antibiotics, ECMO. Okay, so you should be knowing what, very simple word, what is ECMO. What you should know, very few things about ECMO. You don't need to have. What is the basic concept of ECMO?
Sir, it's basically artificial lung, sir.
Okay, so they have a extracorporeal membrane oxygenation. So it means the lungs are not functioning. So you are giving oxygen from outside. Okay. So the difference between ECMO and bypass is, in bypass, there is no pulsatile heart. Okay. There is pump circulation. Here, the heart is functioning, only the function of lungs are bypassing. So you are just giving oxygen by some way because lungs are not functioning. Okay. So I saw somewhere here the high frequency jet ventilation or oscillatory ventilation as well. Only go in that much detail if you have a good concept. Otherwise, these are just the simple things which you should be knowing. And again, in 5 minutes, how much they will ask you. In this time, 5 minutes will be finished. Okay. So that's a good thing. Uh, they might need thoracic approach. So in the thoracic approach, sorry, thoracoscopic repair through VATS. Maybe they are doing it. But again, because this is a subspecialty topic, I don't think so. They will ask you that much detail. So antenatal history, birth history, other congenital anomalies, renal, neurological, musculoskeletal, and how much is the lung pathology, sorry, lung pathology, or only isolated this congenital diaphragmatic hernia or other things as well. Okay, so these few points you should be knowing. ABGs, needs of high frequency ventilation, difficult airway, difficult intubation, pneumothorax can occur. Even sometimes, even after surgery, a number of times they will put chest tubes. Okay, but you should be knowing what's happening. So if you don't know what you are doing, there will be a problem. And again, to start with, I told you that this is again a medical emergency, not a surgical emergency. So they will optimize everything. The homeostatic condition they will try to optimize, and then they will do the surgery, but it will be a long journey. Okay, so these are the things which I have already explained to you in detail. Okay, so actually, because I was thinking that we will be able to finish in one session, but I think one session is insufficient for pediatric anesthesia. So I will, because cough is a little, I want to spend some more time. I will just five minutes we will take for this cleft palate and cleft lip. And then we will finish for today. We will continue tomorrow or day after tomorrow. If tomorrow I will be able to take, because tomorrow I have evening duty. If I finish early, I will do it. Otherwise, we will have session day after tomorrow. So, what is this special things about cleft palate, cleft lip? Yes, please.
Difficult.
Difficult airway with reference to mask ventilation or laryngoscopy. Yes, please. Actually, I was. Can you hear me? Mm, if I'm sorry, actually, I was disconnected. So I think Wajiha think about me and that Dr. Zishan is commenting about my internet. So my internet also collapsed. Wajiha, were you unhappy on my comments about your internet?
Yes, sir, I will change my connection. It will be
No, no, no,
better.
no. Because I apologize because I said something bad about your internet connection and even my mobile was switched off and my internet was gone. Anyways,
Yeah, I
so
wonder. Saudi Arab also has this problem.
no, no, no. Actually, my mobile was off. I did not charge it. So my mobile internet was gone, and now I put on my home internet. Anyways, so that cleft
Okay.
lip, cleft palate. Actually, the things is the difficulty is that because there is a gap. So if there is cleft palate, there will be problem in the ventilation. Okay. So what will be your choice to intubate the baby? Awake.
Gauze piece or weak.
One of the person said like this, and he was failed. Okay, and he is a brilliant person, but unfortunately, he couldn't control the answer. So never, even if you are doing it, say that because there is problem in mask ventilation. So either you will go for inhalational induction with preservation of spontaneous ventilation, or you will go for awake. Okay, awake intubation, or that because don't tell about mechanical ventilation, don't tell about this gauze stuff because this is desi style, this is not the correct. Okay, and here I don't remember recall all of them, but you should be knowing about few of them in this Pierre Robin sequence. What happens? This Treacher colon uh, syndrome. What happens? Only few of the words you should be knowing because they are associated with cleft palate. Okay, so like in this one, there is micrognathia, there is a small mouth, and there is mandibular hypoplasia. Okay, tongue is pushed back high into the oral cavity and then result in typical U-shaped cleft palate seen in over 90% of patients. So you should be knowing few words, not too much details, but you should be knowing about these. At least these two syndromes are commonly they can come in this scenario. If you can remember all of them, that will be great. Okay, this is you see these are the thing which they are happy just to tease you. Charge association, coloboma, heart defect. I don't know actually. Atresia cornea, retarded growth of development. Because pediatric anesthesia, again, I tell you, usually, even I'm working as a consultant, but usually I'm not doing pediatric anesthesia because there are specific pediatric anesthetists who are doing these cases or handling these cases. Okay. Uh, so I think I will stop here. Okay. But the basic, remember one thing. If even if they are asking you about cleft palate, cleft lip, you should be just knowing the basic safety. Abdurrahman, don't tell this gauze stuff. Okay? This gauze stuff is not safe.
Okay.
So I don't think so. You should tell this gauze induction. There is a very good candidate. His name is Zishan also, and he was failed on this thing because he was arguing with the examiner. So I think this is not a very safe answer. And so rest of the things about pediatric anesthesia, actually the time is short. I try to because actually the all topics separately need separate sessions, and I have done a lot of things in my you can find in the YouTube channel. You will find all the pediatrics which I have discussed before, a number of topics in details, pediatric resuscitation, airway, and so many things I have discussed separately. So I will try to cover as much as possible. But again, my main aim is to give you a concept. Okay. Because so many things I cannot recall all the time. I'm not preparing like a presentation. So I'm apology for if I anything I tell them wrongly. You can always correct me. I have no problem in I have no ego issues. Anyone can stop and correct me. Yes, the basic thing is that, which I again and again tell you, that don't overstress yourself. You know your capabilities, you know your limitations. I knew my limitations. I'm so sorry, I'm explaining to you. When I was going for European diploma in anesthesia exam, everyone was afraid of graphs. And believe me, myself, if someone asked me, because there was a question which they frequently used to ask, that how will you correlate ECG, CVP, heart sounds, and cardiac cycle? I understood, I read about it, I understood what happens. But if someone asked me to draw a graph, I am very bad in it. Okay. So there was a fear, and actually so many people fail about it. Believe me, I'm telling you honestly to God. They asked me a similar question about inhalational induction, and actually there was a graph about it. I was not able to draw the graph. Okay. And they because their system is that they give a paper and they give a first question, 15 minutes, just to ease your nerves. They in a start of there are 4 sessions, so in start of every session they give you a paper, and they give you already tell you a question, and you can prepare, you can write about that thing. I did not make the graph. And then when I was writing some of the points, and they, because they were interested in telling me the graph, I said I did not make the graph, I will explain to you. And I explained to them, and they passed me. They did not fail me because I did not make the graph. Okay. So remember one thing. Of course, there will be few examiners who will be teasing you. But if you are only think sadist, if you become sadist and you are only thinking about negativities, you cannot pass. I can guarantee you. Okay. So my aim and objective always is to encourage you guys. I always try to tell you the basic things, the basic failure points, the basic safety points. Because unfortunately, when we come out of the examination hall, may only we remember the things which are the failure points. We sorry, which we think that we fail because of that thing. We create our own failure points, that they ask me about this thing and they fail me. I did not tell this thing and they fail me. No, believe me, the examiners, they are like our fathers or our elder brothers. They are very wise. Okay. They can sense. Now I can understand this thing, that when I am working with any junior resident, in 1 hour I can tell where he falls. What do you think the examiners who have spent their 30 years of or 40 years of their life looking at the residents, even in our setup, unfortunately, because I have very strong feelings about the people who are not training you, and I have very bad words and I have very strong grievances against the system. But it doesn't mean that they are not capable. They are very learned, they are very capable. Yes, they are lazy, they are not fulfilling their duties, but it doesn't mean that they don't know anything. Okay. So remember one thing, nobody in the exam is your enemy. Nobody is going to fail you without any reason. You fail yourself. So again, I have felt, Hamad, you need to improve a lot. I will
Yes,
request you to be focused on the main points. If you know the main points, you will never fail. If you are just trying to recall and cram each and every word, you maybe, and you know your limitations, that you cannot recall everything. Nobody can recall all these things. So you just have to understand the main concept. Okay. So that's what I have done
yes.
in this 1 hour. I have given you, now close the eyes and think from where we started. We started about the physiological, pharmacological, anatomical consideration, but we make them productive by making them correlated with the clinical conduct. So in the exam, you have to tell about the clinical conduct with the reference to endolysis, consent tissue, IV line, airway management, cardiovascular responses, renal system, liver, body fluids, how to understand the fluid status, how to correct it, what are the basics of perioperative analgesia, how to control the temperature, and then we discuss few of the diseases. In the diseases, there are very few, 3 4 points which you should be knowing. And then basic steps of anesthesia, the same induction, the same maintenance, the same recovery, and think about from the pre-operative status to the post-operative status. If anything in which you need post-operative care, you have to tell about post-operative care. If any problem you can anticipate in PACU, you have to tell in the pre. Even you can tell that this patient is prone to have apnea. So either you will never do it as day surgery. You will never do it. You will admit the patient and you will even keep the patient in HD or ICU. Okay, so that you can monitor. So this is how you will make your answer. And always remember the steps of anesthesia: induction, maintenance, recovery, what fluid you are going to give, what monitoring you are going to give, how will you give analgesia, how will you intubate the patient, how will you extubate the patient. These are the things in the common things. Okay, so focus more on these things. So inshallah, either tomorrow or either day after tomorrow, if no class for Dr. Fazal, we will discuss. And don't miss Dr. Fazal classes because he is a gem. He is a gem of a person. Even yesterday, I listened to his all of lecture almost. Okay, so thanks a lot, all of you, for your time, and you are welcome to ask
Thank
anything,
you, sir.
any question,
That was
anytime.
clear.
Okay, Abdurrahman, again, today your answers are very good, but today you are doing a blunder with gauze. Okay, and Wajiha, I am afraid from you because if you will put the cuts, anyone's internet will be closed. Okay, bye bye.
Okay, sir.
ठीक
Shukriya.
है, thanks a lot.
Salam alaikum.